Welcome to SHM's Practice Administrators Roundtable Series, a free resource presented quarterly to our practice leaders and brought to you by the Practice Management Institute. My name is Katie Stevenson, and I'm SHM's Manager of Government Relations, and I'll be moderating today's session. Before we begin, Hospitalist Return on Investment, Measuring and Demonstrating Value to Hospital Leadership, I'd like to share some information you all might be interested in learning more about. First, as I'm sure you know, the 2010 State of Hospital Medicine Report, based on 2009 data, is now available for purchase. You can visit SHM's store to purchase your copy, and be sure to log in to receive your special member pricing. This year, SHM and the Medical Group Management Association have collaborated to add a hospital medicine supplement to MGMA's annual academic practice survey. If you are a hospitalist practice that is involved in teaching medical residents, we invite you to participate. More information can be found on SHM's Practice Management website under the Annual Survey tab, or you can email survey@hospitalmedicine.org for more information. The next SHM webinar, Co-Management of the Hospitalized Patient, Shared Responsibility, Authority, and Accountability, will be featured on October 28th. The course rewards with 1.5 Category 1 credits toward the AMA Physicians Recognition Award and focuses on co-management and how today's hospitalists have an increasing role in the medical management of surgical patients. Registration is now open through hospitalmedicine.org. Now, before I hand it over to our presenter, I'd like to remind you that there will be about a 15 to 20-minute presentation on the topic, and then we will open the floor to questions and answers. If you'd like to submit a question, you can do so by raising your hand using the icon that is within the toolbox you see on your screen. Or you can type your question into the available chat space, which will be sent to the organizer and read out loud for you. If you raise your hand, I will call on you by unmuting you, and then you will be able to ask Dr. Owens your question. Please save all questions until the presentation has concluded. At this time, I'll hand over the presentation to Dr. Thomas Owens, Chief Medical Officer at Duke University Hospital. Dr. Owens, go ahead whenever you're ready.
Thank you, Katie. Good afternoon, everyone. I'm very happy to be here with all of you today and have the chance to talk about a topic which has obviously been very important to me in my professional career. I'll make a bit of a disclaimer here at the beginning. You see from my title that I've actually been the director of a hospital medicine program or series of programs for 8 years now. I've recently moved, some would say, to the dark side and become the Chief Medical Officer for Duke Hospital, so I now sit on both sides of the discussion about return on investment. I think this is a fantastic topic for us to discuss, and I'm looking forward to hearing your input. My goal today is to share some of our experience and some of the experiences that I've had a chance to review from other partner and peer institutions to help develop a sense of how hospital medicine groups and programs can help demonstrate partnership and return on investment to their institutions. When I think about return on investment, I think it really gets down to some fundamental concepts that really deal with clearly understanding goals, both goals for your program, for your physicians and providers, goals for the institution, really taking those goals and developing a sense or an understanding of areas for alignment. And then there's a tremendous focus on effective communication, on methods and tools to assist with communication. And within that communication, it's going to be about data, which is a real challenge for us in many ways, and that's where we'll spend some time talking about opportunities and ways to identify data sources and use those data in a meaningful way. Data really are key, and the experience that I'll share with you around data is that it can be the key to your success or the key to failure in some ways if the data are not of the quality that you're looking for, if they're not representative of the goals and the outcomes that you need to demonstrate in return on investment, or if you don't have buy-in from the key stakeholders, from your physicians and providers, from your administrative team, and from the institution into the quality of that data. And then again, it's really about communication. So when we think about goals and the goals for a hospital medicine program, these are things that we've all talked about for years, that we all live every day. You know, it's really about patients. It's about improving outcome for our patients and our institutions. So there's clear opportunities to understand and highlight areas of alignment. I would say that now more than ever, there's a tremendous opportunity for hospital medicine practices and physicians to identify across the board ways that we and our partner hospitals are clearly on the same page around patient safety, quality, efficiency, effective transitions in care, and also around the financial success of our institutions. We really have an allied mission and vision, and in many ways the public forum and debate has really highlighted opportunities, as SHM and others have pointed out, for us to be aligned with our organizations. It's really the responsibility and challenge for leadership within our programs to fully understand and articulate the ways that our goals align and bring that forward to our internal audience, to our providers and physicians in practice, and then highlight that externally or within the larger audience to our institutions. I think it's really important that at all levels the goals are communicated consistently. I've heard from some colleagues at other institutions really kind of having two sets of reports, two sets of books, what you talk about with leadership, what you talk about with your team and with your physicians. Our approach and what I've advocated for consistently is it's really the same message. The goals are consistent, whether you're talking with your clinical staff, with your administrative team, or the hospital. I think this is also important at the front end when you're looking at recruiting providers, setting the stage so that all new members of the team and all new members of your administrative team as well understand the mission and the approach that your practice takes. Where this is also important, I think, is supporting the goals with policies and procedures, whether that's your compensation plan, your rounding structure, or your review process for the members of your team, so that, again, everyone's on the same page with goals. So I'd like to ask, in terms of thinking about communication, are there scheduled opportunities for you to discuss priorities and communicate your performance to hospital leadership in your current practice?
Okay, so this is the first of our 3 poll questions. Please go ahead and respond to the following question by clicking on the appropriate answer on your screen now. We'll give it just another couple of seconds to make sure that most folks have been able to enter their answer, and then we'll go ahead and close it and reveal the results. Okay, we're going to go ahead and close. And as you can see the results, 9% say no, 58% say yes monthly, 29% say yes quarterly, and 10% say yes annually. We'll return the presentation over to Dr. Owen.
I think what you've all shared here is really great news for our profession and for our organizations. In giving a similar talk to a national audience some years back, this was skewed significantly towards no, that actually many groups didn't have a structured, scheduled opportunity to discuss this. So what I'm hearing from folks is the majority actually have a regular opportunity to bring forward their communication about return on investment, and that's absolutely important. When I've had the chance to listen to some presentations within our own group and others, some of the feedback that I've received from real experts in communication is again getting back to a clear, concise, on-message communication, getting to the key points that we're going to talk about with return on investment. And I offer as advice to folks making these arguments to really understand your audience. The goal of these presentations is not suspense. There should be no mystery in your presentation, and you should give your audience what they expect when they expect it. So even though the message will be the same to your internal audience, your physician team, and to your customers, your institution, or others, the order of the presentation and where you put emphasis may be different depending upon the audience. The other bit of advice I'll offer before we really talk about the meat of the return on investment is in all of these discussions, my advice is to really remain patient-centered, to focus on quality and safety, and I would argue make that part of your first argument for return on investment, to talk about satisfaction, patient and otherwise, to think about efficiency and other outcomes, and either put finance in the middle or end with finance, so that again you're really getting the attention of folks who are focused on patient outcomes, quality, and safety. So in terms of setting the stage within these meetings, again, as you've all outlined that the majority, looks like 86%, have monthly or quarterly meetings, which is a great place to start from. Those meetings are an opportunity to demonstrate leadership and alignment. It's an opportunity to set the stage for partnership and further opportunities. At those meetings, my next sort of polling question for you, do you currently utilize a dashboard or scorecard methodology to report your performance?
Okay, it's now up for the audience to participate. So please go ahead. We'll give it a couple seconds. Okay, we're going to close this in just a second or two to make sure that you get your votes in. Okay. All right, and so our results say 21% no, 25% yes with program level data, 49% yes with program and physician level data, and 11% not yet in development.
Okay, so good. Again, really consistent progress over the years in what I've seen from other programs. Still some opportunities, it sounds like, for some members of our group here today to think about how we might gather some data and bring really a consistent approach to managing data and to presenting it to these meetings or to your audience. In terms of the data, the real challenges that we hear from folks and that we've experienced have been, first off, the quality of the data. How reproducible are the data elements? Do your physicians, your providers, your administrative team have confidence in the quality of the data and the reproducibility? It's particularly important when we start thinking about the non-financial elements of return on investment. Can you hang your hat on them? Can you base even compensation or decisions about strategy on the quality of your data? Another real challenge when we think about some of the new elements of return on investment we're going to discuss is the timeliness of the data. It may not be in the same cycle as financial data with a delay of weeks to months in some ways. And getting back to these first points, really understanding the data sources, testing reporting plans before you really create targets or work plans is critical. The reason I believe dashboards are so useful are to keep people on task, to demonstrate trends over time, and to really get buy-in from the people at monthly meetings, whether it's providers or your external audience, to know how you're presenting data, to know where to look, and to not focus so much on the format of the report because they become accustomed to that, but to focus on the content of the report, which is where you want them to be. So what I would call, with that as the background, what I would call the return on investment version 1.0 that we've been hearing about for years, and I suspect many of us have been using, are to look at the established benefits from hospital medicine programs, from hospitalists. And again, putting patients first, thinking about quality, thinking about the improvements that we've been able to demonstrate with evidence-based care score for the CMS, perfect process measures for pneumonia, heart failure, acute MI, to a lesser extent, perhaps, the surgical site infection work, the SCIP measures. To think about efficiency and the opportunities for, in particular, our institutions that are struggling with capacity management, so length of stay, discharge time, and, of course, the financial impacts of that as well. And then to look at satisfaction. Initially, we focused a lot on referring providers, specialists, staff satisfaction, and increasingly now seeing marked improvements in patient satisfaction related to effective, timely care and transitions. And then, of course, the financial argument for lower cost, in large part driven by length of stay and efficiency gains. All of these elements are still expected as return on investment for hospitalists, and I think form a core foundation to build upon, not to lose sight of it, but to build upon this, and then around these elements begin building a more robust representation of the real return on investment that we deliver. In its simplest form, many of these are very easy to report, and where we started with our institution years back was really looking at trends over time, looking at volumes here and demonstrating the proportion of cases being cared for in the purple bar by our hospitalist group and in the light blue bar by our non-hospital medicine group at one of our core hospitals. We continue to demonstrate return on investment at the entity level within our program. We have multiple hospitals that we serve, and we demonstrate that return on investment by site, and then also in aggregate for our senior system leadership. So this is for one of our hospitals showing a steady shift over time towards hospital medicine providers managing care of the patients. Here's an example again showing patient satisfaction over time in our early version of reports that we've continued to carry forward, showing trends in patient satisfaction. I think it's important in all these reports to, as you'll hear us talk about more later, to talk about external benchmarks, setting goals and targets, and understanding the methodology for improvement year to year. Here, the green bar representing the 90th percentile for our comparison group, which is the Council of Teaching Hospitals National Comparison Group for Patient Satisfaction. Length of stay, again, another example of representative data. When these data are brought forward, I think it's important to provide meaningful comparisons if they're available and to understand bed days saved. So here, for example, this was a year-to-date slide from the middle of this past year showing hospital days saved despite outliers being managed on the hospitalist teams using our non-hospital medicine case mix index adjusted length of stay as a comparison group within our institution. So as a starting point that I suspect many or most of you are at or have moved past, I think return on investment version 2.0 begins to pull in other opportunities to align goals, thinking about other quality elements which may be more difficult to measure, things like readmissions, quality of transitions in care and handoffs, mortality, adjusted or unadjusted mortality, other elements of efficiency, capacity management and outlier management, looking at satisfaction, not only the internal customers, our providers and patients, but also looking at public reported institution perception and reputational scores where they're available. And then on the finance side, bringing in elements of managing RAC audit risk, appropriate assignment of observation and inpatient status, and ability to partner with case management and other hospital leaders around us, clinical documentation and opportunities with establishing case mix index, and increasingly with new opportunities for documentation and partnering around the changeover to ICD-10 in coming years. Many of these projects have really identified opportunities for leadership for our administrative teams as well as our clinical staff within our institutions to help manage these processes. With this come some opportunities to demonstrate savings in other ways, to think about length of stay bed days saved. And here's again an example of one element of return on investment that had been utilized within our institutions. Again, looking at year-to-year cost savings per case, perhaps not true margin, but cost reductions around either length of stay or utilization of resources, savings calculated per clinical FTE based on a ratio of savings per case times the number of cases managed per average clinical FTE, and then program-wide savings to generate an overall return on investment on the finance side, which again for our program has pretty consistently been in the range of 2.5 to 3 to 1 return on investment, looking at the support required per clinical FTE to the overall hospital medicine contribution to savings in cost year to year. For our institution, access has been critical, so length of stay annually and bed days saved have been real opportunities for us. And beginning in the last 2 years, we've really looked at readmissions at 7 and 30 days to partly develop an internal structure to be ahead of the game here as we look at externally reported data and the financial implications with Medicare and other providers around 30-day readmissions, but also recognizing this is a key outcome for our patients and families. I'm going to skip past this readmission to move on and actually show an example of a scorecard that had been used here for FY10. This is our leadership level scorecard for Duke Hospital, which shows detailed level broken down into quadrants: clinical quality, our customer, financial, work culture, which is our internal staff satisfaction and turnover, and then also looking at education and research, which is not shown here as other elements for return on investment. We found that a scorecard, color-coded methodology like this one is extremely useful, again, for the hospital level presentation, and also very valuable to be produced at a monthly level for our group to consume and understand at a glance how we're performing. At the hospital level or at the macro level, we don't report individual physician performance, but we have now developed, for several years, internal reports which show the same level of detail and actually greater detail at the physician level, looking at cases assigned to providers by discharge status. So the discharging provider ends up with the case assigned to them in terms of outcomes, and have used this as a tool for process improvement internally. The consistency in our reports has been a huge advantage, so that if a hospital leader were to approach a physician and ask them their understanding of the goals for evidence-based care scores or patient satisfaction, our providers are engaged in that as well and are really on the same page and able to communicate the same mission, the same goals to leadership. That's been very powerful for us, and I would strongly advocate for using a consistent message across providers and to the institution for that reason. A couple of things to highlight in this kind of a scorecard report, looking at specifically the clinical quality and customer. I think it's important to highlight to leadership in a meaningful way changes that have occurred in your practice and potential implications there. So for example, in changes in population that might affect readmission, and to produce either comments or actually calculated effects of those, and really just put that out there. It doesn't have to be a highlight necessarily in your presentation, depending on the timing, but to have that data available and have people understand the changes in the program and how they've affected your metrics. It's also important to set targets and have a clear definition for how targets are created, whether that's set based upon an external benchmark or internal targets to align with your institutional annual goals. In thinking about finance, this is an area that, again, the math is often the most straightforward and resonates certainly well within our administrative and finance structures. Here, understanding how budgets are set and how year-to-year targets for managing cost and managing expenses and managing revenue are absolutely critical to identify opportunities here. I'm going to skip past this and not spend a lot of time here, but to make the comment that in terms of return on investment, I think managing our resources effectively and being good partners is another way to look at return on investment for our institutions. Looking at staff turnover and the return that you bring by having an effectively managed group that is on target, on message, and invested so that you don't have a lot of turnover will help you succeed. Also, we know that all turnovers have a significant cost, not only the cost of recruitment, but the cost of bringing on a new provider who may be less efficient, less on point with the institutional goals. So what I see ahead with return on investment version 3.0 and where our group has been certainly working, and I see others as well, is really understanding the new disease-specific goals that are coming out and how we can be several years ahead of the curve to help our institutions succeed with public reporting as that comes in the next 3 to 4 years, to really focus on transitions of care, as I mentioned before, and understand how to outline return on investment there, how to use external benchmarks effectively to understand opportunities within the organization and incorporate those into the return on investment calculation. I've mentioned the capacity management and efficiency. And in terms of satisfaction, really looking at the effect of public reporting at the provider level that we see coming down the road in 3 to 4 years. Return on investment in terms of the image for the institution will now increasingly be not only at the summary data level around disease-based, evidence-based care scores, but will begin to be at the physician and provider level. So for hospital medicine groups and employed physicians, we'll be reflecting at the individual level on our institution's reputation in an even more meaningful way. Related to finance, there are opportunities right now to be effective partners in meaningful use in ICD-10 conversion, and we'll need to be at the forefront in demonstrating our leadership and reminding our leaders about the investment they've made in us and the return we're delivering as engaged partners to help the institutions succeed in these very challenging transitions that we face. And then for those academic groups like ours, we have built our scorecards increasingly with academic mission represented, grants, publications, important educational outcomes, and support for changes like the current ACGME work rules that we're all excitedly awaiting the final word on later this week. So my last polling question is to really think about these next steps about how as groups, as administrative leaders, you've incorporated external benchmarks into your performance and return on investment communication.
Okay, you can now go ahead and vote. Give the group a couple more seconds to go ahead and put in their information. Last chance, and we're going to go ahead and close it. So the results were 38% no, 19% yes using external peer benchmarking, 23% using publicly reported quality data, and 30% using multiple benchmarking resources.
Great, and that's, again, to some degree, what I had expected to see looking at many groups who've begun down this journey looking at external benchmark data. I'd be curious in the discussion to hear how that's going for folks and what you found as challenges and what you found has been very successful for you. I'll share that we've used a variety of resources and are increasingly seeing some opportunities to identify where we've been successful and where we need to focus energy. As an academic institution, we've used UHC, and I'll share with you a couple examples of UHC benchmarking. This is one we've used within our program successfully to demonstrate a marked reduction in our inpatient mortality with our hospital medicine program as a targeted quality improvement project over the last really year and a half. The UHC benchmarking data is internal data. It's not used as an external representation of quality, but it allows our institution to look at groups that are peers and to adjust outcomes like mortality and others in a way that we believe is meaningful and to some degree at least is trusted by our clinicians and our staff. What we've seen with these tools, UHC and others, are a variety of data reports that are available that can be very challenging to interpret or very easy to interpret, and we've been sifting through the available reports and metrics to try to identify where we can get the most meaningful information and in a usable form, and either pulling that into our existing quality reports or using quality reports like this one, which is a dashboard of clinical outcomes looking at, in this case, mortality across service lines and diagnoses. I think there's going to be a great deal of work with organizations like UHC and other hospital associations to develop the kind of external benchmarking data and reports and even physician-level reports that we should all be looking to leverage over the coming years because obviously data management is difficult and expensive, and if we can find resources and pooled data to use in a meaningful way, we should take those opportunities. So at this point, in recognizing that one of our goals here is to have time to talk, kind of wrapping up and moving towards discussion, I really wanted to highlight that I think clearly this group, participants, has made great progress moving towards what I would call, again, a third-generation return on investment model for communication, utilizing a consistent approach to communication with opportunities to communicate to hospital leadership in a scheduled way, utilizing an approach to managing data, presenting it in a scorecard or dashboard format so that people know what to expect and how to expect the data format, reaching out to use external benchmarks, which is all great. Again, I would say that the consistency in the message is critical, and that the message is the same whether you're speaking to your internal audience, your providers, your staff, or hospital administration, with only perhaps a varying level of detail and perhaps a different level of discussion about the action plan you put in place to enhance the care that you offer. We have a great opportunity right now with the increasing alignment between the clinical and administrative goals with external clinical quality, safety, and efficiency, and obviously a need for all of us in this somewhat uncertain financial climate to be fiscally responsible, to focus on retaining our excellent employees, and really moving into the coming years with an able workforce and an efficient and effective hospital medicine program. So at this point, I'd really like to stop with the prepared slides and have a chance to have some discussion and see where you'd like to head with this next segment in our talk.
Okay, at this time, we're going to go ahead and open the Q&A. Remember, you can either raise your hand or submit your question in the chat function, or I'm sorry, in the questions function of your toolbar. Please make sure you have your audio pin activated if you plan on raising your hand. That information is also in the audio section of the meeting toolbar. We will share the presentation with the participants via email after the presentation has concluded. So we will post, and we will also post that online. So we'll go ahead and start with one of the submitted questions. Do you measure physician participation in policy or process development, i.e. adopting silver impregnated Foley catheters to reduce infection, or PFOs?
So actually, as an institution, we have looked at adoption of new policies, whether it's the catheter-associated bloodstream insertion bundle, and we treat that as a team outcome. So we look at it as a process-level outcome for our care units. But one element, and I didn't show you all the elements in our internal process for it, is looking at compliance with the bundle around catheter-associated bloodstream infections and catheter-associated urinary tract infections, and then outcomes, the actual events, the rate of infections that we see. So we have looked at that. One of the challenges we found with those sort of process scores are that within our systems, at least, it's somewhat labor-intensive to gather that data. We don't have as good of automated reporting as we'd like to have for those process measures. We have a much easier time with outcomes, with the actual infections themselves, than we do with the process.
Okay, next question. Can you give other examples of benchmarks that we can use besides UHC and MGMA?
Yes, and again, depending upon the areas that we're looking for benchmarking, some of the data that SHM provides as a part of their annual surveys can be useful in areas of finance. I think looking at published literature where available can also be useful, whether that's looking at catheter-associated bloodstream infection rates and data published in the New England Journal about what might be achieved with process improvement, or publicly reported data at the state or regional level around evidence-based care scores, etc., are certainly useful places to look. Increasingly, I think we're going to need to identify organizations, whether it's hospital associations at the state level, national organizations like SHM, as partners for us to share outcomes data to help us benchmark our performance. I'm trying to think of some other good examples in sort of non-teaching areas. There are other organizations that obviously help manage data for CMS, the Premier Group and others, which again largely focus on the CMS measures, but increasingly some of those data providers will be focusing on what we expect to see over the next 3 to 5 or 7 years, and we'll be introducing some new outcome measures that they'll help provide data management resources on. I think the external benchmarks will remain a challenge for us, though.
Okay, we have a hand raised. So Peter Elsey, you can go ahead and answer your question now. You are unmuted.
Hi, thank you very much for a great presentation. This is very useful. I'm calling from Western Massachusetts, Coley Dickinson Hospital. In the course of generating our dashboard, we were able to bring our length of stay down pretty significantly, about 3/4 of a day per patient. And when I went to working on the value of that, we had a lot of different numbers posed as far as the value. We've seen values anywhere from $500 to $800 per bed day saved. However, when I negotiated with the hospital about what those numbers really meant, they said really they could only count actual durable goods, pharmacy and other things saved. So a big debate for us is what is the value of one hospital day?
Yes, and you're not alone in that, Peter. So we've had some similar discussions, and I think depending upon your relationship to the hospital, whether you're an employed group of physicians or a contracted group or private practice with a purchase service agreement, I think there may be some different ways that return on investment could be looked at as a part of a contract negotiation. I think the other factor that plays a role that we've been able to capitalize has been issues of capacity management. So when you look at some of the data that I showed before about cost per case saved, which for us has run around $1,400 compared to an internal comparison group of other non-hospital medicine providers, the majority of that savings has been in length of stay. And we've looked at pharmacy utilization, lab utilization, radiology, and other buckets to understand whether our prescribing patterns or practice patterns really produce that reduction in cost or whether it is length of stay. And for us, it's largely been length of stay. Where we've been able to capitalize has been looking at opportunity costs that patients who, as an institution, we either turn away or we delay access and care because of bed availability. And so particularly during our busiest months of the year, about 9 months out of the year now, where bed availability is critical, we've been able to capitalize and articulate a return on investment for the cases that are brought in place of those. And we actually don't really look at a cost return on investment per bed day saved. We look at, as we displayed it, opportunities, total bed days saved, and then allow the hospital to understand how many cases they could bring in instead of the patients that we discharged early. Okay, I'm not sure if I answered your question, but that is a challenging one, I recognize.
Okay, our next question, given the pressures placed upon the middle management, specifically the program medical director, how do you set realistic expectations with hospital administration to prevent burnout?
Oh boy, that is a good one too. So in thinking about understanding the time commitment for middle management, whether that's physician or provider leadership or administrative leadership, and the amount of time required for a program of a given size, etc. We've, and I won't say we've got this right, and we've talked with colleagues at other institutions about this as well who struggle. Early on, there were some calculations and other things proposed in terms of the amount of effort for an administrative physician leader as well as an administrative manager for a given program size. I think most of those calculations now have kind of gone out the window as again, the real opportunity for hospital medicine is focusing on quality, safety, and other outcomes, which are very labor-intensive and require substantial leadership investment. I think what we have tried to do with some success, I think, has been to outline strategies for leadership and incentivize leadership. Within our compensation plan, we do pay for leadership for our rank and file physicians, and so we've been able to kind of distribute leadership among our team so that our medical directors can coordinate those efforts, can be resources, but that a lot of our on-the-ground performance improvement and management can be accomplished by a team of our physicians working at the unit level or at the at a process or a project level. We still struggle, frankly, to determine the level of physician leadership at that sort of middle management level that's required for a program, and we've I think done a pretty good job of focusing on quality and outcomes and tying that to the involvement of our physician leaders to justify time. But again, I don't know that we've got that right yet. We probably have some real opportunities there.
Okay. Regarding version 3.0 and future disease-specific goals, can you comment on particular diseases that might be addressed?
Sure. So obviously, some have been outlined for us by the Center for Medicare and Medicaid, looking at chronic lung disease and COPD as one clear target that's going to come down the road. Diabetes care we all thought was going to be a clear target, and then with conflicting evidence and no clear guidance, I don't see that diabetes inpatient management will be highlighted there. There are many surgical complication-related metrics that I think will certainly come into play in the next 3 to 5 years. So depending upon your program's involvement with co-management or surgical care, I think those will absolutely play a role. So for those that are working closely with orthopedics and neurosurgery and others, I think we'll have to pay very close attention to surgical site infection management, perioperative complications, and again, catheter-associated infections and complications. The other medicine-based diseases that I think we will see increasing focus on will be probably moving past just the CMS evidence-based care scores for CHF and acute MI, and really thinking about the interplay between length of stay and readmission rates. There's growing evidence, as you're all aware, that reducing length of stay in specific diseases like heart failure is strongly associated with higher readmission rates. And so many of us believe that there'll be some alignment of quality metrics and goals to help bring into play readmissions as well, and length of stay as a part of that. What I think we're all looking for will be a more clear communication and kind of roadmap for what diseases or what targets might be developed within CMS or from other agencies looking at quality to help highlight those. The process measures that we believe we'll have to come to grips with, again, as a part of meaningful use, communication with patients and providers, so providing electronic access to documents within 72 hours of discharge for patients, providing a connection for referring providers and communicating care with them. Those elements will be across diseases, but will obviously be critical for us to be at the table and to be partners in helping our hospitals succeed with those.
Okay. Do you have private hospitalist groups at Duke? And if so, how do the private groups present their ROI to hospital administration?
So we actually do not have private hospital medicine groups at Duke or within our partner hospitals at this time, and that's a really good question, and it's one that I don't have a lot of personal experience with. I have visited some other institutions that do have private hospital medicine groups, and again, I think that in many ways the communication is the same, with a focus on quality and safety, just as I've outlined, focusing on the patient first, and then around bringing revenue to the institution, bringing cases, supporting private practices in meaningful ways, etc. I think one of the challenges for those private practice groups may be, and again I don't know this for sure, but in some institutions it seems to be really having access to institutional data and being able to articulate then the effect on institutional outcomes, whether it is, again, quality, safety, or patient satisfaction in a meaningful way. And I think if I were managing in that situation, I would look up front to develop an understanding and relationship with the performance services or quality management groups at the hospital and try to develop a relationship for quality reporting at the physician or service line level, and then be able to use that data to articulate return on investment.
Okay, Caitlin Foxley, your mute is off, so go ahead and ask your question.
Well, I just wanted to make a comment. This is Caitlin Foxley. I'm with the Nebraska Medical Center, and I'm the medical director of the private hospitalist group. And it's to comment on the previous question. We're at an institution that has both a private and an academic hospitalist group. And so we do our reporting in a scorecard type of way. And I think that the key to success is that we do have access to the institutional data, and we work closely with the administration to develop our numbers and report our data in such a way that's similar to the academic teams. And actually what's interesting is we found our data is very, very similar to the academic hospitalist teams. And from my understanding, we're one of the few programs in the country, in fact the only one that I know of, that has both an academic and a private hospitalist service.
That's great. Again, you developed a relationship to have access, which I think is, and it sounds like a real partnership, which is critical.
Okay, next question. How do I approach an administration that is very reluctant to share financial data?
Boy, that's a good one. My own approach to leadership has been one of really complete transparency. So we have, I'll take a step back here and say that the way Duke has been organized historically is that our physician practice is actually a separate entity. It's a limited liability corporation, technically a for-profit private practice of physicians. Our hospital medicine group, however, has transitioned to be fully employed. We're actually the only employed physicians at Duke University Hospital, and we have employed physicians at our partner hospitals as well that are part of our team. One of our challenges when we were in our faculty practice status was really developing a true, transparent relationship with the hospital so that they felt completely comfortable with our financial data and that we had access to theirs. So we did change our model to create an atmosphere and really a state of transparency, which I felt was critical for our success. What I guess I would ask the person with the question would be, have you been able to develop a reporting structure that allows you to be transparent in a way? And again, I really expect that in return. I do think there are opportunities to talk about return on investment without the financial data, although clearly that's going to play a substantial role in articulating the benefits of the program and opportunities for reinvestment of your financial return. So I would really set the framework as one that really expects transparency and really requires that for success of both sides, the hospital and the program.
Okay, our next question is all your information also shared with your team, and how do you help them continue to push the message of alignment with Duke?
So we share all of our data with every member of the team, and actually we have a physician level report and then program level report, and on a monthly basis we send out physician level data that shows our entire team performance, and all members of all physicians see everyone's data. And when we transitioned to that about 3.5, now almost 4 years ago, that was a bit of a challenge for us. We did that again in this spirit of complete transparency and hopefully to identify best practices within our group and allow mentoring and/or opportunities for people to take leadership roles around areas like satisfaction, clinical quality, etc. So our culture now, I think, has largely adjusted to the fact that with this month's data, the group can see my clinical performance data and every other member's at the individual level, and they see the roll-up and the net effect on our program. We do not share physician-level data outside of our program, so it's not viewed by hospital administration, it's not viewed by department or other leadership, it's only within our program. And I think that level of comfort, our faculty are good with right now. But the goals are at the same level across the board. The way the data are communicated and prioritized is the same whether we're dealing with our physicians or hospital administration. Again, month to month we may highlight specific opportunities or specific successes to one audience or the other, but the overall message is the same.
Okay. What numerics did you compare yourselves to show a decreased rate of readmissions, internal non-hospitalist data or other data?
So we're really doing both now. So readmission data is quite challenging. As you know, we'd all been waiting for guidance about what would be potentially publicly reported and what Medicare would alter their reimbursement based on, whether it would be readmission for all cause or related to the discharge DRG, and what specific DRGs would be in that group. Our hospital tracks readmissions only at the entity level, so only at the hospital level, even though, frankly, we have a system, we don't track readmissions to any of our sites, which has been one of our challenges. What we look at readmission data at our institution level, and we've tracked that over time. We have not adjusted that for severity of illness. We look at it across all DRGs, so it is pooled data. And we've also looked at, again, since it's all-cause readmission, these could be scheduled readmissions for a follow-up procedure or for a planned way. So it's getting a little bit at the balance of reduced length of stay, even though a patient might be readmitted for a procedure in a week. And so we now are recognizing in an increasing way that some of our efforts at length of stay may impact our readmission rate. The external benchmarks that we have available, there are some vendors now and some organizations, including UHC, that have offered an opportunity to compare readmissions if they have access to PHI on your patients to identify them in Medicare or other databases. As an institution, we've chosen not to participate in that because of not wanting to share a PHI on our patients. We do participate in UHC, which provides benchmarking at the institution level, so readmissions only to Duke for our Duke patients, and we can compare that to peer institutions. We're really just starting down the path of looking at readmissions, so most of our benchmarks are historical performance. And we've tried to drill down at our readmissions by DRG, look at opportunities where we believe either disease management could be used as an intervention or where we recognize that patterns in those patients represent an opportunity for a better safety network in the community or better transition care team planning within community resources. We're early in that journey, though, and we have a lot to learn as well.
How do you deal with physician resistance to measurements at the provider level with the inherent attribution issues, e.g., who is the physician in the Press-Ganey survey, same for clinical outcomes, length of stay, etc.?
Yeah, and again, we struggled with that for several years, and we looked at data, we started reporting data, we had a lot of opportunities to talk about it. We recognize this is a team sport, so the discharging physician is being held accountable, if you will, for satisfaction, for cost, for some elements that really represent the entirety of the care effort, all members of the team. We're also a teaching institution, so much of the care we provide is in concert with residents and students, and again, elements like satisfaction and cost clearly represent not only the day-to-day communication interactions, but also the ordering practices of our learners. So we know there's variability here. Because of the limitations in data, you have the opportunity of using the admitting provider or the discharging provider for many of these metrics, and so by convention, as a team, we agreed we would use discharging provider, recognizing that specifically for patient satisfaction, the discharging provider has a substantial effect on satisfaction. What we've done within our scorecard, we show the data by provider and by team. We set targets that are consistent for both, and we actually incentivize performance at the patient satisfaction level with half of the total dollars available designated for group performance and half designated at the individual provider performance. It is, again, not perfect, and we know we have opportunities around this. One of the other things that you might ask in this is looking at outliers, and do we remove outliers, statistical outliers from the pool when we're looking at performance or incentives? And that's again been a journey for us. We do that in some ways around length of stay. We're beginning to do that around some readmissions for a handful of targeted patients with very high readmission rates. But for patient satisfaction, we do not do that. We look at really the pooled data. It's been a process over the years, and I think our physician group now is pretty on board with this and just recognize this is the way we practice. We do also share this as a philosophy at the time of recruitment with our physicians, so they come to our group understanding this is the way we practice.
Okay, we have about 3 minutes left, so we'll try to get through 1 or 2 more questions. If we have not answered your question by the time that we conclude, please feel free to email it directly to P as in Paul, M as in Mary, Institute at hospitalmedicine.org. So that's pminstitute@hospitalmedicine.org, and we can go ahead and forward those to Dr. Ellens to answer. So probably the final question is, for your ROI version 1, what did you set or choose as baseline data to make the calculations on cost per case and length of stay?
So we used historical data, recognizing that our hospital's performance plan and annual work plan was really set looking at year-over-year improvement. As a reality check, we did use published data on expected improvements in cost and in length of stay to understand not so much our baseline length of stay, but whether the changes that we were seeing were in line with what other institutions had experienced. where in the slides and what I'll again release to everyone showed some bumps in the road where we had narrowing of our performance. We attempted to attribute that we looked at that critically to understand whether that was related to changes in our model, for example, poor staffing and high census per provider and thus less efficient care, changes in population, perhaps outliers that could have been in the hospital medicine group. As we've grown and had the opportunity year to year to understand our data more fully, what we've tried to do is articulate again those exceptions or outliers, the 500-day length of stay patient discharge this past year, but still include all that in the data and still demonstrate a return on investment year to year. I think the other question that you could ask is whether you use raw length of stay or a case mix index adjusted length of stay, and I think increasingly a case mix index adjusted length of stay is the right target for both the institution level and for the program level.
Okay, that concludes today's roundtable. Thank you very much for all of those who participated. On the conclusion of the presentation, you will receive a brief survey asking about your experience today shortly after we conclude. Any information you can provide will be helpful in future roundtables. You will also be receiving an email once the presentation is available online. Thanks again and have a great day, and especially thanks to Dr. Ellen.
Thank you all.